Hi everyone, welcome to our multi-heart lecture series. Today we have Dr. Alan Snyderman that will be speaking about why we should measure and treat apoB. It's a great honor to have here Dr. Snyderman, who is the Edwards Professor of Cardiology and Professor of Medicine at McGill University. He's the director of the Mike Rosenblum Laboratory of Cardiovascular Research at Royal Victoria Hospital in Montreal and was elected a Fellow of the Royal Society of Canada in 2009. Dr. Snyderman obtained his MD from the University of Toronto in 1965 and then moved to Montreal, where he did his clinical training in internal medicine and cardiology at McGill University. In 1971, he went to the University of California in San Diego to study lipoprotein metabolism with Dr. Daniel Steinberg. He then returned to McGill, and with the passage of time, he became the Edwards Professor of Cardiology and Professor of Medicine at McGill University. So Dr. Snyderman has done extensive work on the commonest lipoproteinemia that is associated with coronary artery disease, that is the hypertriglyceridemia and hyper-apoB. He's published extensively in the topic, including publications in JAMA Cardiology, Circulation Research, European Heart Journal of Cardiology, European Heart Journal, JAC, and others. So in the setting of increasing interest in apoB, we thought about bringing sort of the father of apoB and the person that understands it the most. So we're honored to have you here to teach us a little bit about apoB to all of us. Thank you so much.
Thank you, and I thank you for the generous introduction. It's a pleasure to be able to be with you, at least electronically, and I'm honored to have received this invitation to speak. The title of my talk is Why We Should Measure and Treat apoB, because knowing and treating his or her apoB could save your patient's life, and also because knowing and treating your own apoB could save your own life. In 2019, the European Society of Cardiology, European Atherosclerosis Society, in their guidelines, stated that apoB is the preferred measurement to further refine the estimate of ASCVD risk that is modifiable by lipid-lowering therapy. Standardized, automated, accurate, inexpensive methods to measure apoB are available. Furthermore, the analytical performance of apoB methods are superior to LDL cholesterol and non-HDL cholesterol. They gave apoB a full-throated endorsement. Nevertheless, LDL cholesterol remains the standard metric of therapy, with non-HDL cholesterol advocated by a number of reputable authorities to be superior to LDL cholesterol. apoB has not penetrated into regular clinical practice because the American guidelines have not highlighted the utility of apoB. Now, apoB is the total number of atherogenic particles. Shown on this slide are the atherogenic lipoprotein particles, of which there are a number of different kinds. There are the lipoprotein particles secreted by the intestine, the apoB 48 particles, the intact particles and the remnants. They carry the dietary cholesterol and triglyceride. There's the apoB 100 particles secreted by the liver. These are the precursor particles, the VLDL particles, and the LDL particles. You can see that the LDL particles vastly outnumber the VLDL particles, about 8 or 9 to 1. LDLP is a measurement of the number of LDL particles. LDL cholesterol's the mass of cholesterol in the LDL particles. Non-HDL cholesterol is the mass in all the particles. You can see in your bottom right, the LP little a, those little guys, there aren't many of them, but they're very robust villains. And their effect on atherogenic risk is not captured by total apoB. By contrast, apoB, which includes all the apoB particles, captures, I will demonstrate to you the atherogenic risk that's been estimated from triglycerides, non-HDL cholesterol, and LDL cholesterol. So what's more important in determining the risk of events? The number of apoB particles in plasma or the mass of cholesterol within the apoB particles? What is the evidence? Because we should be practicing based on the evidence. This slide summarizes the evidence from multiple sources, from conventional observational studies. If we're looking at apoB versus LDL cholesterol, 23 out of 27 studies favor apoB. One only favors LDL cholesterol. Mendelian randomizations, out of the 6, 1 favors LDL cholesterol. Both of the studies that favor LDL cholesterol come from Iceland, it turns out. Meta-analyses, all 3 meta-analyses favor apoB, although to differing degrees. And the discordance analyses, which I'll show you, they all favor apoB over LDL cholesterol. So there's no question that if you take all of the evidence, apoB is superior to non-HDL cholesterol. So what about non-HDL cholesterol? Because non-HDL is the cholesterol in all the apoB particles. And it's already available from a standard conventional test. If you look at the observational studies, 1 favors non-HDL, 7, they're mixed, 9 favor apoB. So that the balance of the evidence favors apoB, but there are a substantial number of well-conducted studies in which the non-HDL cholesterol turned out to be as atherogenic calculated as the apoB. And a major part of the reason for this is that the standard statistical methods to analyze variables are not designed to deal with highly correlated variables. Because cholesterol is such a major constituent of all the apoB particles, there are extremely high correlation coefficients amongst LDL cholesterol, non-HDL cholesterol, and apoB. Indeed, in UK Biobank, they're over 0.95. That's a problem for conventional statistical methods. In meta-analyses, one meta-analysis did favor non-HDL cholesterol. This was a statin treatment trial, a review of statin treatment studies. 3, including a review of statin treatment studies, favored apoB. Of the discordance analyses, and that's what I'm going to try and teach you most about. Discordance analyses is a statistical method that we devised that to deal specifically with the situation of when you have highly correlated variables. Because even though LDL cholesterol and non-HDL cholesterol on one hand are highly correlated with apoB, actually, there's substantial differences, I'll show you, in the amount in individuals, in the amount of cholesterol in their apoB particles. And so what we do is isolate the individuals, identify and isolate the individuals in whom the cholesterol mass differs, and look at that group, because that's the group in which the predictions will necessarily vary, and we can test which marker is correct. Now, these next couple slides are conceptually what I hope you focus on. I got 2 patients up here. In your hospital, you get the concentration of the different markers. You get the amount expressed in terms of concentration. So I've shown in patient 1 and patient 2, the C's are cholesterol molecules, the interior, the lumen of an artery, and with equal numbers of cholesterol molecules. So that patient will have equal LDL cholesterol or equal non-HDL cholesterol expressed as milligrams per deciliter. But oil, which is cholesterol, and water, which is plasma, do not mix. So the cholesterol molecules are not distributed in plasma. They're aggregated in particles, soap bubbles. And around the exterior of the soap bubble is one molecule of apoB. This demonstrates two patients with the same cholesterol, but a very different number of
We lost you for a second, but if you want to reshare again, you're muted. So if you hit the microphone,
Okay, yeah, I'm
yeah,
unmuted now.
yeah. If you want to share screen again, we'll be back.
Yes, please. You told me I pushed the big button. The
The
share
green one,
screen is the green one,
and then PowerPoint.
and then PowerPoint. Got it. Okay, we're good.
We're good. Thank you.
Thank you. So the forces of darkness intervened. On the top, I don't know how far I got on this one, but this shows you that the number of particles in the lumen of the artery is the prime determinant of the number that get trapped within the vessel wall. And it's the ones that get trapped within the vessel wall as opposed to going harmlessly through that are the fundamental cause of atherosclerosis. Everything else, hypertension, diabetes, impacts the rate at which these particles are trapped. And it's the rate and number that are trapped over time that determine your atherosclerotic risk. Smaller particles do get into the wall more easily than larger ones, and they bind to the glycosaminoglycans within the arterial wall more easily than the large one. So in that sense, the smaller ones are more dangerous. But the larger ones, when they do get trapped, they deposit more cholesterol. So it turns out that it's the number of particles, not their composition, that matters so much. And that's why apoB is such an accurate summary of the total risk that's created by the VLDL, LDL particles, and indeed the small number of remnants that are present in plasma. Now let's look at some randomized controlled trial evidence because that's the highest form of evidence we have actually. This is our meta-analysis of the clinical trials, and you can see at the bottom, we had 8 clinical trials that we looked at. And when we integrated them, either using conventional meta-analysis or Bayesian analysis, it really didn't matter. apoB was more highly related to risk than was non-HDL cholesterol or LDL cholesterol. Brian Ferenz in 2017 in JAMA demonstrated that no matter how, if you can see here, he isolated the genes that would correspond to a statin effect, ezetimibe, PCSK9, and so on. You can see them all listed here. No matter how he manipulated the levels, the benefit per standard reduction in apoB was the same, from which he concluded that if you're looking at a lipid benefit, the metric that is truthful all of the time is apoB. And the CETP trials have certainly demonstrated the validity of that finding. These are data from the Copenhagen General Population Study, in which they looked at, I think it was about 30,000 individuals in Copenhagen who were on statin therapy. And you can see in the top panel, which is a discordance analysis, that LDL cholesterol, when it's higher than apoB, it does not predict risk. It underestimates risk, whereas when apoB is higher than LDL cholesterol, it correctly predicts risks. The same thing is true for non-HDL cholesterol, and this study demonstrated that all-cause mortality was higher in the discordantly high apoB versus non-HDL cholesterol group. These are data from the Fourier from an IMPROVE-IT study, as well as UK Biobank. On the top panel is shown that apoB is in UK Biobank is better than non-HDL cholesterol and TG. And on the bottom panels, you can see that apoB is better than non-HDL cholesterol, which is not significant once apoB is taken into account, and same thing for triglyceride. These are data from the Odyssey outcomes, and you can, and in that study also, apoB was a more accurate marker of outcome than either non-HDL cholesterol or LDL cholesterol. So in the only trials that we have of super therapy, of aggressive therapy, intensive therapy, apoB more accurately predicts residual risk than LDL cholesterol or non-HDL cholesterol. I think that has overwhelming significance for how we should practice. When we talk about the agents that change LDL cholesterol and non-HDL cholesterol, I'm often asked, well, what agents change apoB? That's not the real question. The real question is, why does LDL cholesterol and non-HDL cholesterol go up in plasma? They go up because the number of apoB particles secreted into plasma go up. They go up because fewer apoB particles are removed from plasma. They can go up if you increase the cholesterol content of apoB particles. What makes them go down? It's changing the number of apoB particles in plasma, decreasing them, or decreasing the cholesterol content of apoB particles. Cholesterol changes because apoB changes. How do statins, zetamides, PCSK9s lower ASCVD risk? By lowering the number of apoB particles. Fibrates, you can see that statins on the left, they reduce VLDL particles moderately and LDL particles hugely. Fibrates reduce VLDL particles a lot, but only modestly reduce LDL particles. Do fibrates reduce cardiovascular risk? Nope. They do not. And they do not because they do not substantially reduce total apoB. I'll give you a couple of cases. The pictures are, not real, but the numbers are. 50-year-old woman, is she at increased risk due to her apoB lipoproteins? These are the data that you would have available to you. The non-HDL cholesterol is elevated because it's the 77th percentile of the American population. The LDL cholesterol is elevated because it's the 82nd percentile. So you would have to conclude, you would have to tell this person that they were at increased CVD risk, and you would be wrong. Her apoB is 90 milligrams per deciliter, which is the 53rd percentile. She has a normal number of cholesterol-rich apoB particles. That's a phenotype that's common in women, and it's associated with health, not with increased ACVD risk. The TG is low, the HDL cholesterol is high, her glucose will be totally normal. So you would be misled and you would mislead your patient. Same thing, next one, we've got a lady whose non-HDL and LDL cholesterol are average. Is she average and therefore not at increased risk? Nope. Her apoB is 115 milligrams per deciliter. She's at the 84th percentile. So I emphasize the pictures are not real, but the numbers are. And the patients were. Who's worse than whom? I got 3 patients up here. I got 5 numbers in each, and you're supposed to assimilate all 5 numbers. In some of them, the TG is higher, and some the LDL cholesterol is higher. The non-HDL doesn't look very different. The HDL is down in one. Who is worse than whom? I got it. All I had to do was get the apoB. With the apoB, you unify data, you clarify data, and you simplify complex data. Here's a patient with cardiovascular disease on rosuvastatin 40 and ezetimibe 40. His LDL cholesterol 65. Does he need increased therapy? Of course he does. His non-HDL and LDL cholesterol are at the 10th percentile, but his apoB is at the 35th. 35th is not low. This individual will benefit. The group, anyway, a group of individuals with these values will benefit because there's enough apoB particles to reduce to actually change outcome. If we take diabetes, the conventional view of the world is high TG, LDL cholesterol, normal. For 20 years, they were treated with fibrates. If you take apoB, and you see that most of them have a high apoB. That's why statins worked in diabetics. That's why we should be treating diabetics with statins, ezetimibe, PCSK9 inhibitors. Now, the evidence shows, I think, unequivocally that apoB is a better marker than LDL cholesterol and non-HDL cholesterol. But that's a statistical outcome. You could ask, and fair question, how often does that difference occur, an important difference occur? How common is clinically significant discordance? And there's now a body of evidence to deal, and it's a form of discordance. These are data from a recent paper we had in the European Heart Journal, in which we looked at UK and we did, first of all, we did a regression line, and you get the difference between the measured and the between the measured and the predicted apoB, and look to see how that, the residual, and see how that's related to risk. And when we do it for apoB and non-HDL, apoB is significant, but the residual of apoB, the difference that's not accounted for by apoB, non-HDL contributes nothing. If we reverse it and look at non-HDL, apoB adds signal. So it beats non-HDL. UK Biobank is a huge database, 500,000 people. And I think in this study we had over 300,000. And we divided them up. We took a number of levels of non-HDL cholesterol, 100, 130, 160, 190, 220. So we covered the distribution of non-HDL cholesterol. And on this slide, you can see the distributions of the subjects who had non-HDL cholesterols plus or minus, I think it was 5 milligrams per deciliter, around that number. And we have about 20,000 of them in each of these groups. And you can see that the range of apoB for people who all had effectively the same value of non-HDL cholesterol was 26 milligrams per deciliter at the low end and 32 milligrams per deciliter at the high end. So even at the lowest levels of non-HDL cholesterol, there was a substantial absolute variance in apoB. Now, did that matter? We then took the top 16%, you look on your right, the top 16% in green here, versus the number of events in the bottom 16% for each of these groups, for the 190, the 160, 130, and 100. And what we found was that except for the lowest where there are too few events, but the trend was actually exactly the same, there were significantly more events in the people with the high apoB with the same non-HDL cholesterol or LDL cholesterol, it's shown on your left, compared to the bottom 16%. So this proves absolutely, definitively, and unequivocally that discordance is common. When I have a clinic, this is what I see in my clinics. This is what you would see in your clinics if you measured apoB. It's what you miss in your clinics with your patients if you do not measure apoB. There was a paper recently in JACC from Copenhagen General Population Study by Martin Mortensen and his colleagues. And what they did this, they did it for LDL cholesterol, and they did a slightly different form of variance analysis. They took the regression line for the people with perfectly normal triglycerides, and then they looked at the distribution. On this slide, you can see the distribution of values of LDL cholesterol versus apoB. And even though the correlation coefficient between LDL cholesterol and apoB is 0.98, I think, you can see that it's a cigar, not a cigarette. That at any given value of, look at, say, for example, an LDL cholesterol of 155 and go up, there's a substantial range of values for apoB. And they then examined the increment in risk as those values go up for women and for men. And you can see that for both women and men, in women, it was true for mortality as well as clinical events, that as the excess apoB goes up, the risk goes up. So that absolutely confirms what we found. These are data from a recent publication by Dr. Syed and Anne-Marie Navarre from the University of Texas at Houston in JAMA Cardiology, and they looked at the metabolic concurrence of discordant apoB, and you can see that in both men and women that there's substantial discordance in apoB. In race and ethnicity, there's substantial discordance. In diabetics, there's substantial discordance. In obese people, there's substantial discordance. In metabolic syndrome, there's substantial discordance. And in people on statins, there's substantial discordance. So this is an American database. So this demonstrates in the US, this applies as well. What does the evidence establish? One, apoB is a more accurate marker of risk, cardiovascular risk, than LDL cholesterol and non-HDL cholesterol. Two, apoB is a better marker of the adequacy of therapy than LDL cholesterol and non-HDL cholesterol. Three, I haven't dwelt on at all, but apoB is a more accurately measured in the laboratory than LDL cholesterol and non-HDL cholesterol. And this has been affirmed by the American Association of Clinical Chemists, the European Federation of Clinical Chemistry, and it was contested for quite a while by a number of American lipid experts, but nobody actually contests it now. And I've got the picture of Santika Markovina from the University of Washington, and Santika was a stupendous achievement. She created a standardization program for apoB, and the reality is that the measurement of apoB is standardized. The measurement of LDL cholesterol and non-HDL cholesterol are not, because they haven't, and you can't standardize the measurement of triglycerides, and HDL cholesterol is an agreed upon method. It isn't that these methods are poor. They're not bad. They're just not as good. And this is the area, the final one is the area that we're working on, that apoB would be cost saving. And I can't share all that data with you now, but it's in the works. The fact is the test for apoB in my hospital, the cost is about $5 Canadian. So that's about $3 US. In the United States, costs and charges are two different things. But we estimated that even using American charges, accepted charges, which would be around $20, $25 US, that the actual cost of measuring apoB on every sample would add about 0.8% to the cost of care of total lipid therapy. The testing is a trivial part of the cost of care. It's the outcome of care that counts. It's how accurately you identify patients that counts. It's how clearly you communicate to patients what their problem is and how well they're doing with it that counts. When is the measurement of LDL cholesterol sufficient? There is no patient in whom the measurement of LDL cholesterol is sufficient. Full assessment of a lipoprotein-related risk of ASCVD requires measurement of a conventional lipid panel plus apoB plus Lp(a). And if you aren't doing that, you aren't practicing what I would suggest to you is acceptable modern therapy. I haven't covered with you how you diagnose unusual dyslipoproteinemias, but it can't, like type 3 hyperlipoproteinemia, a life-threatening, unusual dyslipoproteinemia, but it can't be done without a lipid panel and apoB. Non-HDL cholesterol is better than LDL cholesterol, but apoB is better than non-HDL cholesterol. America is not or should not be about second-class medicine. If you select non-HDL, that's a second-class choice. The assessment of the adequacy of therapy only requires a measurement of apoB. Once you've decided to treat the patient, you don't need to look at 5 lipid numbers to know if you've achieved your target. You don't need to report all those numbers to the patient because they're not relevant. The relevant number is apoB. I tell my patients they've made the grade when their apoB is adequate. And I can tell if they're taking their medicine by knowing their apoB. To summarize, not everything that is faced can be changed, but nothing that can be changed until it is faced. The work on cholesterol has been brilliant beyond description. I get it that we, the medical establishment, have invested much in the education about cholesterol. But if we have a better way of identifying those human beings that we're responsible for who are at increased risk, then we just need to move on as we have moved on in every other area of medicine. I suggest to you, I don't suggest it, I'm telling you, we're losing lives because we are not measuring apoB. We have lost lives because we did not measure apoB. That should not be acceptable to you or to your colleagues or to your patients. I'm done. Many thanks.
Thank you very much, Dr. Snyderman, for the amazing lecture. It's still controversial, unfortunately, but as you've proven very well, there's strong data proving that apoB is a better marker. So if anyone has questions, please put them in the Q&A. I don't know, Mario, if you have a first question you would like to ask.
Yeah, I actually have a question here. Going back to the cost issues, I actually were digging around, and the average cost is listed somewhere between $100 and $200, or the average charge here in the U.S. versus 30 to 40 for LDL and 40 to 60 for lipoprotein A. So the question that I have for you is, if we measure apoB, do we need to measure Lp(a)?
Yes, you do need to measure Lp(a) because it conveys independent information. In terms of your charges, I don't know your source of those numbers, but it illustrates a problem, a challenge that we have, because the cost is not that. And part of the cost driving apoB is that the guidelines haven't recommended apoB, so people are not, insurance companies are able to say that it's experimental and not fully approved, and make it difficult for doctors to order it. When it's the cost of measuring LDL cholesterol is $3. You're being ripped off. I mean, this is absurd to pay 10 times the cost. LDL cholesterol, 10 times. In a cost-constrained world, when a large numbers of people don't have access to care, this is absurd. So it's not just an ApoB problem on the cost, it's a cost problem. And I think that no knowledge should mean that it should be unacceptable for those kinds of charges, because $100, your Medicare approved charge is $20. That's what Quest would charge you, okay? That's what the big companies would charge you. They're not going to charge you $100. They're going to charge, I think it's 20-25. I mean, that's the range. Not $100. And I don't know the actual Quest charge or something for, or LabCorp, because I'm not associated with either one of them. But they could actually measure apoB for nothing in their standard panel. So we have a problem in the system, and that problem should not continue to diminish the quality of the care that you're able to give.
Thank you very much for the answer. We have a question from Ed Pittman. He says, what is your view of the recent NLA expert consensus statement on apoB?
I've read it quickly. I think it's actually two statements. If you read within the document, they've got a lot of the evidence that apoB is superior. If you look at the highlights, what the highlights say is non-HDL cholesterol and LDL cholesterol are better than apoB. So the implication is that non-HDL cholesterol and apoB are equivalent. And that's not correct. I signed, okay, with respect, it's a challenge. I know something about how the document was constructed. So I think it's a challenge for organizations that have taken a position in the past to move beyond the position that they've taken. I've actually never been part of any panel that reviewed apoB. Oh, once for the NLA about 30 years ago. And that, I think, is because I'm regarded as an advocate, which in less polite language, we zealot. But on the other hand, there are people who legitimately, based on their own observations, had results that were not favorable to apoB. But that was earlier on, when the data was less, when the methods statistically and biologically were less good. So they've got positions too. And I think we've got to move beyond that. I think that I have a problem. I don't have a problem with evidence-based medicine. But as a teacher, I have a problem with guidelines and consensus, because our cardiology fellows now, their primary teaching are the guidelines, whereas my primary teaching was evidence. And I was being taught how to reason, how to challenge, how to interpret. And I was taught the insecurity of all our knowledge. All of our knowledge is incomplete. We always are going to know more tomorrow. So every answer we have today is provisional. And I think that an unfortunate but extraordinarily consequential outcome of the guidelines has been the appearance of certainty when actually it's uncertainty. We do the best we can with imperfect information. That covers every area, every question of medicine I know. And most of my clinical work is, I'm not a lipidologist. I'm not a cardiologist as I was, but when I was really practicing cardiology, it was to identify the problem in the specific patient. How much was aortic stenosis? How much was mitral regurg? How much was coronary disease? How much was the renal failure? And integrate all that and take into account how good the people at my institution were at dealing with it, either surgically or interventionally. That's my discipline of cardiology, not a rote application of guideline-directed medical therapy. It's not that we do need this process. It's absolutely essential that we have our colleagues who are expert review it. But if we step back and just apply what a group says, then we've lost, we're no longer participating. We're just rote applying. So if the European guidelines said apoB was better, how can the NLA not say exactly the same thing when all the data in the intervening time has been apoB is better, except for one study? How can the NLA not come out in the same place as the Europeans did? That's a challenge, because I don't think the Europeans are stupid. I just think the panel was constituted differently. The only evidence since 2019, except for one study, is all favorable for apoB over non-HDL. So how can they be different?
Well, thank you very much. It's a very insightful and important discussion about the data, and important for our fellows to take this into account when they read statements or consensus in general, regardless of the NLA, more as a general concept. So we have a very good question from Daniel Lorenzati that he asked about you talked about apoB. What about the remnant cholesterol measurements as compared to apoB or triglyceride-rich lipoproteins, for example?
There's a rich and fulsome scientific debate going on now as to whether the remnant particles need to be measured in addition to apoB to further refine risk. The Chris Packard and Jan Boren in particular, and Nordisgaard, they argue from their data and their analyses that the remnant particles add both to non-HDL and apoB. Our analyses, and I think those of others that I've seen papers in the pipeline, don't accord with that. And I think that's an active issue that's, we'll see how it turns out. It's based on differences in the conceptualization of the analysis. I don't want to make it sound it's obscure, but it's technical. And that's legitimate scientific discourse that's collegial and constructive and positive. So I don't think, except in type 3, I don't think they add that much. I think the cholesterol-rich remnant particles are a little more atherogenic than the LDL particles. But the difference only very occasionally makes any difference. And it's not relevant clinically. But we'll see how that all turns out.
Thank you very much. We have a question from Anchor, one of our first-year fellows, that he asked about the variabilities in ethnicity or race in related to the increased risk that the AHA has recognized in Southeast Asian heritage. And if you know if there's any data looking at different ethnicity changes with apoB and in particular in Southeast Asian descent.
That's a great question. And the data I know, the strongest data come from the Inner Heart study. And the Inner Heart study included all the major peoples of the world. And it showed that apoB was better than LDL cholesterol and non-HDL cholesterol in all the major peoples of the world. The dyslipoproteinemia that's characteristic of South Asians, I mean, obviously there isn't one, but the most common one is higher triglycerides with a high apoB. The cholesterol may be normal or slightly elevated, moderately elevated. And I think it's related to differences in adipose tissue metabolism. And I think it's just as it's well known that metabolic syndrome and dyslipidemia are more common in South Asians at lower waist to hip circumference ratios than Caucasians. I think that's pointing to differences in adipose tissue metabolism, and my hope is that people will return to looking at the causes of dyslipoproteinemia and trying to understand the basic metabolic differences, because I think that the increased predilection of Southeast Asians is related to comprehensible pathophysiological differences, but it's going to require, but we need to focus on them and study them. So I welcome all kinds of research that documents how we as humans both look like each other and don't look like each other. And from those we can infer the general biological processes that regulate everything in all of us.
Thank you very much. One last question. I'm going to ask, we know the lower the better, you know, for LDL, for apoB, but what about the thresholds? We have a variability, you know, of numbers between the European, the American, and this concept of the apoB over 130 as a risk-enhancing number. What should we use as a number? What to use for your patients?
The 130 number in the I think it was the 2018 American guidelines. I have no idea where they get it from. I mean, it's a number. It's equivalent to about the 90th percentile of the population. That's not the above 120 is equivalent to the LDL cholesterol of 5. Okay. And so for me, there's a number of other areas that I haven't talked about. One of the, and more important than apoB is I select patients based not just on their risk, but on the benefit of therapy. And we can calculate what the benefit of therapy is, because the benefit of therapy is related to all the factors that determine risk, plus the impact on risk from treatment, because you only, let's say, treat the apoB. So it turns out that people with lower apoB but higher risk can benefit just as much as people with higher apoB and lower risk. And people that look like they're at low risk but have a high apoB, they can benefit very substantially. So I base my treatment on this, and I'd be glad to send you. We had a paper in JACC Advances summer, reviewing all of this, and it's a different concept than you're used to. But my principles of treatment are: one, treat young. I think that the risk model that's currently recommended by everybody is incorrect because it uses only 10-year risk. And when you're 30 or 40, your 10-year risk is low. But when you get to 50 or 60, what's happened is your risk gone up because the disease developed during the time you weren't treating it. And I think we need to transition to earlier intervention. And we've published models documenting how much we would expect the outcome to be improved. In people who are already at risk, I lower apoB as much as I can. I get it down to 50. Okay. And I don't grade my reduction on primary, secondary. To me, it's primary prevention is two groups: people who have no disease and people who have an infarct that hasn't happened yet. And we can't distinguish between the two. And I think that you're going to see the most amazing progress in the years that are to come, as we can image much more accurately the wall, not just the lumen of the artery. I think we're about to just multiply the opportunities to identify and select and treat and monitor therapy in ways that are unimaginable now. So I envy you the joy and that you're going to have as we move forward, and I hope get away from these models like the 10-year model. That's like 50 years old. Man, it's out of date. So it's a long-winded answer to your short and perceptive question. But I think a lot's got to change. Or I would like a lot to change, because we have therapy and we're just not using it very intelligently. We've got to, if we want to seriously impact the cost in human and societal terms of vascular disease, we're in the amazing situation of having therapy and not using it wisely. So I hope that people your age pick it up and move it forward.
Well, thank you very much. That was an amazing answer. So, and an amazing lecture as well. We really enjoyed it, and hopefully we'll have you in crazy New York in the future visiting us in person.
Well, I'd love to come and make rounds with your residents and actually do cardiology and see just how good you guys really are.
Thank you very much. We'll stay in
Make that
touch.
happen.
Okay. Ciao. It was a fabulous honor to meet you, even
Thank
if
you.
so remotely. Thank you. Take care.
Bye-bye.